Oh, thank you, Karen. What an amazing story. I love hearing from survivors and just hearing how much that inspired you to do more in giving back to those who are potential survivors of the future. Our next speaker, Retu Saxena, MD, is a cardiologist at Minneapolis Heart Institute. Dr. Saxena, who was recognized as a 2022 top doctor in cardiology and cardiology for women in Minnesota Monthly, and a 2022 top doctor in Minneapolis St. Paul magazine, has expertise in women's heart disease, non-invasive imaging, and critical care, as well as specific research interests related to cardiovascular risk factors that emerge during pregnancy, and also gender differences in heart disease. You've probably all heard that there are differences in how heart issues present themselves in women and men. As part of her work with the MHIF's Penny Anderson Women's Cardiovascular Center, she has provided training to more than 150 OBGYN and women's care practitioners to help them better manage risk among their patients as part of MHIF's BROACH initiative, which is broadening the role of OBGYNs in assessing cardiovascular health. Dr. Saxena previously served from 2016 to 2019 as a member of the ACC Minnesota Board of Counselors and was active in community work as a participant of the annual Midwest Cardiovascular Forum. She currently serves as the first female governor for the Minnesota chapter of the ACC. She graduated from the University of Minnesota Medical School and trained at Oregon Health and Sciences University and the University of New Mexico. Let's hear it for Dr. Saxena.
Hi, I'm Dr. Retu Saxena. I'm a cardiologist and researcher at the Minneapolis Heart Institute and Minneapolis Heart Institute Foundation. I also happen to co-direct our cardio-obstetrics program, and I'm going to talk to you today about gender differences in heart health. I'm going to start with a year. In 1908, heart disease officially became the #1 killer of women in the United States, and it's remained so since 1908. In about 2020, which is the last set of statistics that we have, heart disease was responsible for 441,532 deaths of women. And this is all ages combined. Women represent about 48% of all deaths from cardiovascular disease. Cardiovascular disease is also a very expensive problem. In 2016, it was the first listed diagnosis for 2.2 million women who were discharged from short stay hospitals. And about 2018 to 2019, it cost, this is just for women, $154 billion. As you can see here from this graph, about 1980 or so, 1985 or so, women used to die far more often than men from heart disease. We actually all natored, both men and women, in about 2020, and we actually hit clinical equipoise about 2013. Since then, we've all been having increasing rates of death from cardiovascular disease, men and women. And for a while, women were lagging behind those rates of death. Yay, but we're catching up just as quickly with men as of 2020. And so again, heart disease, #1 killer of men, but definitely #1 killer of women. When we break down the causes of death in this country, coronary heart disease, heart attacks, things that lead to bypass and stents, make up the majority of those deaths. Stroke is responsible for about 17%. Other heart disease, such as valvular disease, congenital disease, make up about 17%. High blood pressure, we'll talk about that a lot, makes up about 13%. Heart failure from any cause makes up about 10%. And here's about diseases of the arteries. And this is where we look at things like aorta diseases. And that's about 3% of the deaths in the United States. And this is from 2020. When we think about aortic disease itself and gender differences, not much is written and not much is studied. There's actually a fairly lacking amount of information dividing aortic disease by men and women. But we do know the incidence of abdominal aortic aneurysm has been increasing in the last 2 decades. It is far more common in men than women, with a prevalence rate about 1.3 to 8.9% in men, and about 1.0 to 2.2% in women. For thoracic aortic disease, there isn't a lot of data about the difference between men and women, other than what I'm going to present in a second. But the prevalence and incidence is about 5.3 per 100,000 individuals per year, with a prevalence that's about 0.16 or 0.16% living with heart disease. And this is for the United States. When we look at genetic conditions or familial conditions that lead to thoracic aortic issues, when Marfan's, being most common, is equal in men and women, but bicuspid aortic valve disease with a dilated aorta is more common in men, familial aortic disease more common in men, and then even thoracic aortic aneurysm disease with a size less than 5 centimeters is more common in men. So more often than not, men have more thoracic aortic disease as well as abdominal aortic disease, unless you look at Marfan's. So anytime I give a talk, I could be giving a talk on how to make the best sourdough pizza or cookies. I will throw a slide or two or maybe 5 about maternal mortality. I co-direct our cardio-obstetrics program, and maternal mortality in this country is really important for me to raise awareness about. When we look at maternal mortality in the United States over the last few decades, it's been steadily increasing to a point where I would say it's quite woeful. In 2018, the US government passed the Preventing Maternal Deaths Act. With that passage, every year since, our maternal deaths per 100,000 live births has been increasing. So this is 2018 in the blue, 2019 in the green, and then 2020 in this brownish maroon. And every single year, we've had an escalating number of women die during pregnancy or in the postpartum period. If you happen to be a non-Hispanic Black woman, those numbers are incredibly atrocious. You are 2 to 3 times more likely to die in pregnancy or in the postpartum period than white women. The same is true for Hispanic women. But again, it's those non-Hispanic Black women that carry the burden of this. So why, as a cardiologist, would I add in slides about maternal mortality? Well, when you look at why these women die, about a third of them actually die due to cardiovascular conditions, those same cardiovascular conditions that all other Americans die for. So about third, 33%, are cardiovascular related. Again, 9%, and this has been steadily increasing, are hypertensive or hypertensive disorder of pregnancy related. And so nearly 50% of these deaths are things that cardiologists, such as myself and the other people here talking, deal with day in and day out. Now, these causes do vary by race. Preeclampsia, eclampsia, and embolism were the leading causes of death for Black women. Mental health problems are more often than not to lead to death in non-Hispanic white women. And most of these deaths, about half of them, actually occur after delivery within that first 42 to 45 days postpartum, what we in medicine now call the 4th trimester. What's really important, other than raising awareness about how women while pregnant are more likely to die, is that most of these deaths are preventable. And so this is data that was published actually a while ago from California, which is one of the only states in the country that has actually reversed their maternal mortality deaths. And what they found is that when they look at women who died and they looked at why, almost 90% of the cardiovascular disease, 100% of the high blood pressure disease deaths, and overall about 89% of all deaths in these women could have been prevented. And they could have been prevented by paying attention to clinical warning signs. Now, you're going to hear this, and you're going to hear this a couple times from me. Clinical warning signs. These are the same, whether this is my 90-year-old female patient I'm seeing in clinic, my 50-year-old patient I'm seeing with shortness of breath or valve issues, or my 30-year-old pregnant woman. And this is chest discomfort, shortness of breath, difficulty breathing at night, swelling in our feet, our heart racing, pounding, or skipping, passing out, having a headache, or having issues with our blood pressure. Just these simple symptoms, had we asked and paid attention to them, would have led to about 90 to 100% of these women who died during pregnancy or in that postpartum period being alive today. So what about pregnancy and aortic disease? Not a lot of data, but the very large study that was published last year called the ROPAC trial actually looked at bicuspid aortic valve and thoracic aortic disease. These are patients with Marfan's, bicuspid aortic valve, familial thoracic aortic disease, vascular Ehlers-Danlos, which is another connective tissue disorder, as well as Turner syndrome. And this was a total of 189 women. And actually, most of these women did really well. Of the 189 women that got pregnant and carried through pregnancy, only 4 cases of dissection were found. All 4 of those cases were in individuals who hadn't had a prior history of a dilated aorta. There were no side effects from the most commonly and recommended treatment, which is beta blockers. The new guidelines for aortic disease that were just published in November of 2021 recommend that women who are pregnant with any predisposition to aortic issues or have aortic issues be maintained on a beta blocker. So if you happen to have Marfan syndrome, Loeys-Dietz, vascular Ehlers-Danlos, or a hereditary type of thoracic aortic disorder, and you're contemplating getting pregnant, it's important for you to be seen at a center where genetic counseling is available, as well as a discussion about your risks through pregnancy are, especially if you have things like Marfan syndrome. The recommendation is also true in those individuals who have bicuspid aortic valve disease with aortic dilation. There's a recommendation for appropriate evaluation, usually with 3-dimensional imaging, such as an MRI or a CAT scan prior to getting pregnant. And talking about maybe a pregnancy heart risk team. In those individuals who have an aortic issue, the recommendation for beta blocker therapy during pregnancy and the postpartum period is recommended unless they have low blood pressure or they're not able to tolerate it. And so again, beta blocker is super important during pregnancy. So let's switch gear and talk about just women and heart disease in general. Turns out that women are not small men. We have differences, we have hormonal differences, we have gender bias, and we tend to do worse. We know our symptoms are different. We present differently than men do. Although there's this idea that women don't get chest pain is still present in about 50% of women, and it's usually seen in younger women. Older women, however, tend to present with symptoms such as shortness of breath, or what we term dyspnea, and that's present in about 60% of people. Fatigue and weakness can also be seen in women as a manifestation of any heart disease, including aortic disease. Usually when I talk to women about chest discomfort, I say discomfort that occurs anywhere between your chin and your belly button, can be between your shoulders, can be into your jaw, your neck, your throat, or your chest, especially if it's worse with exertion or emotional stress, and or better with rest. This can be a sign that something is going on with your heart. Women can also have nausea, breaking out to a cold sweat, lightheadedness and dizziness can also be present. So our symptoms are different, and because our symptoms are different, and we have a issue with awareness for heart disease in this country, we often blame other things for heart disease. So a few points to hit home. Heart disease is the #1 killer of women since 1908. But our awareness as women that heart disease is the leading cause of death in the United States and worldwide is quite low. So the American Heart Association in 2009 did a survey of women to look to see what they thought of as the #1 killer of women. And at that time, about 65% of women, and these are primarily Caucasian women, because in Hispanic and not Black women, what we found was it was about 35% of those women recognized heart disease as the #1 killer. But 65% of women were aware in 2009 that heart disease was the #1 killer of women. We redid that survey about 2 or 3 years ago in 2019. And at that point, it had dropped quite drastically. Only 44% of women recognize that heart disease is the #1 killer of women. And women actually now think more often than not that cancer is the #1 killer of women, and breast cancer is the #1 killer of women. Now, a lot of women live with breast cancer, and very, very fortunately, because breast cancer is near and dear to my heart, women with breast cancer do not die from breast cancer. In fact, only about 30,000 women a year die from breast cancer, which is fabulous. 450,000 women die from heart disease, which is not good. More often than not, women who have breast cancer will actually die from heart disease. But because there's this lack of awareness, and our symptoms can be a little bit different or not the same as what we think of in Hollywood, what we tend to do is we minimize our symptoms. We're usually very busy taking care of our kids, our family, everybody else to seek care, or we attribute our symptoms to something else, and then we get missed, and we prolong our suffering and prolong our point till we get to be evaluated. When we do show up to the emergency room, we are still underappreciated for having heart disease. In 2021, a very large hospital in New York took a look at young women, so women under the age of 65, who presented to the emergency room with chest discomfort. These weren't short of breath. These were women who had typical chest discomfort, the thing that you see on TV. Women who presented to the emergency room were less likely to be triaged as an emergent case. We were more likely to have to wait for an EKG, less likely to receive heart monitoring, and we were less likely to be evaluated in the hospital, admitted for observation, or seen by a cardiologist. So, in general, medical personnel are less likely to refer to cardiology, less likely to refer to stress tests. And although most primary care providers recognize cardiovascular disease as a top health concern in women, health things often prioritized by most primary care providers in OBs tend to be weight related, or bikini related, so breast health or uterine, ovarian health. And most physicians, including cardiologists, report suboptimal training in assessing cardiovascular disease risks in women. Those risk factors are different, but not significantly. Our traditional risk factors say the same. Women who have diabetes, smoking, hypertension, they have a little bit more risk than men. We'll talk about hypertension a lot. But the regular risk factors, such as our cholesterol, obesity, inactivity, and our family history, they're weighted the same in men and women. High blood pressure. Part of the problem with high blood pressure is we're not very good at controlling it. Both diabetes and smoking confer a slightly higher risk in women than in men because of the way our arteries are designed. There are emerging risk factors that are really important in pregnancy, in women. One is things that happen to us in pregnancy. Turns out that hypertension in pregnancy, such as gestational hypertension or preeclampsia, having a preterm birth, so having delivered a baby before the age of 30, fetal age of 36 weeks, or having had a small for gestational age delivery. All of those things increase our risk for having cardiovascular disease. Gestational diabetes not only increases our risk for developing diabetes, but also increases our risk of having a heart attack, even if you don't develop the diabetes. Things such as lupus and rheumatoid arthritis increase women's risk for developing heart disease more so than in men. And then menopause, if you happen to have it early, increases your risk of ischemic heart disease. And then depression and stress we'll talk about quite a bit, but depression for women and heart disease is not good. So let's talk about adverse pregnancy outcomes. Adverse pregnancy outcomes include things like preeclampsia or eclampsia, which used to be called toxemia. It's a severe form of high blood pressure that occurs to us about 20 weeks into pregnancy. Gestational hypertension, which is a milder version of a hypertensive disorder of pregnancy. So these adverse pregnancy outcomes that lead to hypertension during pregnancy come back and haunt us later in life. It turns out that if you've happened to have a pregnancy associated with high blood pressure, you are, in every 5 years of your lifespan, apt to be more likely to have hypertension. By the time you're a 65-year-old woman, 80% of these women are likely to have some degree of hypertension. Remember, we're not very good at treating hypertension in this country for women. But not only are we at increased risk for developing hypertension, we're at increased risk of developing heart plaque or coronary artery disease. Heart failure, in fact, if you happen to have the worst sort of hypertensive disorder of pregnancy called preeclampsia or eclampsia, your likelihood to be admitted for heart failure in the first 10 years after that delivery is very high. But we're also more likely to have valvular disease. And so when we look at those adverse pregnancy outcomes, not only does it put us at increased risk of having any kind of cardiovascular disease, valve disease, heart failure, heart attacks, it absolutely increases our risk for hypertension. It also increases our risk for stroke, and then it increases our risk for diabetes. And so if you have these conditions, or you're at risk for these conditions and you're pregnant, it's really important to pay attention to your blood pressure, your cholesterol, your weight, and your diabetes risk, and be followed on an annual basis. So when I say women are not small men, I mean that we are different. Our heart arteries are different. We have smaller diameter arteries. They're not as robust and as plump as these big juicy blood vessels that my friends like to put stents in. We also have less focal narrowing. Our narrowing is less apt to be a simple thing where we can put a stent in, and our narrowing is less apt our plaque is less apt to be calcified. We have more soft or vulnerable, apt to erupt plaques. And we have a lot of microvessel dysfunction. So I'm a very interesting human being in that I carry around this picture with me in my pocket. It's now on my phone. And what we find is that these are the big vessels that we stent, but it's actually these little tiny microvessels that actually feed the heart muscle. And women have more microvessel dysfunction. We absolutely have heart artery disease associated with atherosclerotic plaque, things that need to be stented or bypassed. But women are more likely to have microvessel dysfunction. We're more apt to have vasospasm where the artery just closes. We tend to be more at risk, especially if we have a underlying arterial issues such as Marfan's or Loeys-Dietz or fibromuscular dysplasia, of having a torn heart artery called spontaneous coronary artery dissection. And we're more likely to have broken heart syndrome, which is a stress-related cardiomyopathy. So where the heart acts like it's having a heart attack due to an overwhelming acute stressor, but the heart arteries themselves are not blocked. So we call that Takotsubo or broken heart syndrome. So just really quickly, stress and the heart. So women are at huge burden of stress, anxiety, and depression. Turns out that those individuals who feel their stress in our brain's fear receptors, so these are brain PET studies, and what you're seeing right here is the light up of the amygdala or the fear receptor. Turns out the more active you get your amygdala, the more inflammation that the heart arteries see and the increased risk of having cardiovascular disease. So stress, chronic and acute, leads to an increase of all this pro-inflammatory cytokine production that leads to atherosclerotic disease. And it increases our risk for heart attack, stroke, and other serious heart events in the next 3 to 4 years. With that, we know that women who have depression also have an increasing risk of developing heart disease. And so women with the worst form of depression, this is something called a PHQ-9. This is how people are measured for a depression outcome. Those that have the worst scores are more likely to develop coronary artery disease, need things such as bypass and stents, which is this red line here, or actually lead to death. And so we know that the prevalence of depression is quite high, both in men and women. It's about 20% increased in those individuals that have had a heart attack, but it's twice as high in women as in men who've had heart attacks. Very, very common in women under the age of 60. And as you can see, if you happen to be a woman under the age of 60 with bad depression, you're more likely to not do well. And in those individuals with ischemic heart disease, depression not treated can increase our risk for passing away. So our risk factors are different, our arteries are different, we have this lack of awareness. We know that women are not evaluated well, but we're also not treated the way we should be with guidelines. We have a lower rate of treatment for after we've had a type of heart attack, where we have to rush you to the cath lab. We're less likely to achieve door to balloon time in 90 minutes, which is our guideline standard. And we're less likely to be appropriately given medicine that help our heart muscle recover. We're absolutely less likely to get appropriate testing, as I mentioned, but when appropriate, we're less likely to be referred for getting our arteries opened. Things such as atrial fibrillation, which I'm not going to talk about just due to lack of time, but in atrial fibrillation, women who are at higher risk for having strokes are less likely to get the appropriate blood thinners to prevent strokes. We're less likely to get cholesterol treatment. We're less likely to be followed on the guideline-directed medical therapy. And for me, we'll talk about this again in a second, we have a higher death rate from high blood pressure, and we're less likely to be appropriately treated. So heart disease in general, women are more likely to, after a heart attack, to die in the first year than men. We're more likely to die from after coronary artery bypass grafting and have more issues. We have a worse quality of life because we have more chest pain and we have a higher incidence of things like heart failure. What about aorta management in women? Well, we're more likely to have hypertension. Because of that, we're having an increase or a faster rate of growth than men do. Although 70% of aneurysms occur in men, women are more likely to have dissection. We have delayed intervention because we wait until women are operated on a larger size relative to our height. We tend to be shorter than men. And after repair, we tend to do worse. And again, I think that's because we wait too long and we have other comorbidities. And so we're more likely to have complications such as stroke and other heart disease related strokes. High blood pressure, super important. if I teach you nothing else, I'm going to teach you to get your blood pressure checked, because your blood pressure not only can impact your arteries in the aneurysm, it can impact heart attack risk, kidneys, heart failure, and then of course stroke. But it's one of those simple things that we can get evaluated and get managed, especially if you've had pregnancy associated hypertension problems. Super important to know what your numbers are. Normal is now less than 120/80. If you're above 135/85 and you've had no other risk factors, no hypertension during pregnancy, your aorta is perfectly sized, then you wait until it's a little bit higher to get treatment. But if you're diabetic, have a large aorta, have a vascular condition, may have had pregnancy associated hypertension, we start thinking of keeping you below that 130/80. And really managing those risk factors, just like managing the risk factors for really everything we do when it comes to heart disease, is keeping your blood pressure under control, moving more, trying to eat a healthy diet, lower in salt, controlling your blood sugar, controlling your cholesterol, and gosh, if you smoke, quit. I think 80% of what I do is preventable, and a lot of that can be managed through lifestyle and diet and really good medicine. So a long time ago, now we're into decades ago, I finished medical school. When I finished medical school, we were taught that something magical happens in a woman's life at menopause. Well, for those of you who have been through or are going through menopause, you know that it is not magical. But we used to believe that when you hit menopause, that's when your risk for heart disease would actually be important and that we should pay attention to it. I'd like to turn that paradigm on its head. I actually think that we should start prevention in our 20s and 30s. We should look at pregnancy. 80% of patients who can get pregnant. Look at pregnancy as an opportunity to think about risk for things like aortic disease, high blood pressure, high cholesterol, heart artery disease, and start looking at younger and younger women to help prevent them from developing issues when they're older. Uh-oh. And with that, I'm going to leave you with this. Women are understudied, underrecognized, underdiagnosed, undertreated, and underrepresented in clinical trials. About 35% of all deaths are made up in women. This is worldwide. In 2019, 275 million women worldwide were diagnosed with heart disease, and about 9 million women died from heart disease. I think it's really important for women to pay attention and be aware that heart disease is the #1 killer of women. If you have issues such as blood pressure, cholesterol, aortic issues, it's important to follow up with your cardiologist or your primary care provider and be appropriately treated. Work on that lifestyle modification. And I'll leave you with this. Since I do research with women in heart disease, think about enrolling in a clinical trial. Like I said, we have very little data about thoracic aorta and gender differences. Those are really small trials I presented. And so anything we can do to improve the research will help women later that come behind us. So with that, I leave you with thank you.